Tēnā koutou katoa, ko kapiti ti moanga, ko tainui ti waka, ko paipaitonga ti moana, ko hikitanga ti paia ti hapu, ko Ngāti Rakawa ki ti tonga ti iwi, ko Cass Byrnes tāko ingoa, hirata hua no mo ngā tamariki ki ti whetu kai poki. Tēnā koutou, tēnā koutou, tēnā koutou katoa. Jocelyn actually gave me this title, which I think is really a great title because bronchiectasis is indeed a growing problem. It's a growing problem in terms of numbers, but it's also a growing problem when you hear from Anna and Cameron about their girl growing, with bronchiectasis. And we're seeing increasing numbers of children who will be coming through again with bronchiectasis. There's a few things that I thought we might highlight, and thank you for inviting me to be part of the conference, which is terrific, as I go through. And one of the things I just wanted to say about all of them is that we set the bar too high. So we set the bar too high to make a diagnosis, to refer, to get treatment, and some of the treatments we can't even get, even though we've got a severe problem. Now, this is very basic, but I was also mindful that perhaps people will be coming onto the website and looking at talks later, and I wanted to make sure everybody knew what we were talking about, especially perhaps non-health professionals that might be coming through. So we all know that it's airway damage and mucus retention and recurrent infections, and damage can go from one area, if not treated, to a widespread disease, and sometimes even with treatment. And one of the problems, as I see it, is that the diagnosis is with a CT scan. And we should really think about this. Bronchiectasis is a clinical diagnosis. If someone is coughing, if they're producing mucus, and that might be more obvious in an adult, but a wet cough in children, or if they're having infections, then don't wait. That's enough. That's bronchiectasis, and you can start treatment as you would while you refer. The kind of bar too high here is the CT scan, and part of that is getting access to it, and part of it is the concern about radiation. And we just looked at our last 56 children over less than 2 years, new diagnoses at Starship, and looked at how many x-rays they'd had prior to coming in for a review. And they'd had between 5 and 25. Well, there's like 4 CT scans just there. And if you fly to and from the States in a plane, well, I guess you wouldn't fly any other way, if you fly to and from the States, closer to the sun, that's your CT scan. So we should really lower our threshold. And one of the issues is just that onset of symptoms, be they severe infection or chronic cough, and diagnoses, if you look over several studies that have looked at children and you just look at the sort of ages between, you can see that the gap is between 4 and 5 years, and that's far too long. So why such a concern in New Zealand? We did a prospective study looking at new diagnoses over a 2-year period and showed that it was, it was very high in Pacifica and Maori, but all of this is too high compared to other countries. Clearly we have hotspots, again, all too high compared to other countries. Clearly we have an increased admission rate. But look at this most recent report, just published in 2014, looking at children 0 to 14 years of age, 136 admissions in 1 year of individual children with bronchiectasis, and 1 death every 18 months. This is the death of a child of bronchiectasis less than 14. And in adults, bronchiectasis complicates many other disorders or respiratory disorders and probably contributes to their difficulty in management. So you can see that about 40% of those who've got difficult to control asthma, when investigated, have the comorbidity of bronchiectasis. And Conroy Wong in South Auckland followed 152 adults with bronchiectasis, and they had 307 admissions in 1 year, and at least 46 required a readmission, and 21% died in the next 12 months. And why it's a concern in New Zealand, looking at comparative data between Alaska, Australia and ourselves, the top table just looks at what the degree of disease was at time of diagnosis. And these represent different papers describing different clinics of children with bronchiectasis. It's not surprising that our children have bilateral disease because it's usually post-infectious, but it's just a marker of severity. And you can see that although there's significant bilateral disease already present at diagnosis in children from Australia and Alaska, I mean, look at the New Zealand data. So in children in Auckland, 87% at time of diagnosis had bilateral disease, and 83% in the national cohort. And 2/3 of these, this was widespread. And in the lower box, this is children that are diagnosed with bronchiectasis and were admitted into an intervention trial, and again a comparison between the groups. And you can see that while there are lots of respiratory tract infections in Australia and Alaska, certainly in the New Zealand group, there were far more admissions before the New Zealand group got to be diagnosed. And the ranges for the New Zealand group that I've put here far outstrip the other two. We also followed up children who were admitted with severe lower respiratory tract infection, seen 1 year later at a time that their parents thought were of time of health. And you can see that despite that, 2/3 of them had ongoing respiratory problems, some more than one of these, with a chronic cough, crackles or clubbing, and persisting chest X-ray abnormalities. I'm going to just move to what to look out for. So growth, clubbing, chest deformity and crackles is what we have traditionally associated with bronchiectasis. And now once again I want to say the bar is too high. In the most recent guideline, we have suggested that wet cough not responding to 4 weeks of antibiotics or 3 episodes of cough or a persisting chest abnormality should get a referral. Now they might be able to follow this in Australia, but we're nowhere near this. You know, we have kids coming after 2 years of coughing, and you heard from Lance O'Sullivan that one of the boys he was talking about had 5 years of abnormal chest X-ray. So I wanted to come back to try and bring the bar lower. What should we look out for? Sure cough, recurrent infections, hospital admissions, recurrent antibiotic use of any type, school absenteeism. When we were discussing this on the way in, we had both, Lance O'Sullivan and myself, both come to the conclusion that this is a wasted opportunity. It's easily recorded, and if a child had something like 20% of away school days in a year, we should send a social team and a health worker team into that household and to try and help that family. It's a clear and easy pick marker of things going amiss, and the others is noted there. The other thing too is that, let's say you saw a child and they might have 1, 2 or 3 of these problems, and you referred them in to a paediatrician, and let's say they didn't have bronchiectasis. Well, hallelujah, it would be the first one. A prize, I think. Now we have good management guidelines, and I wanted to touch on one thing. I'm going to run for 3 more minutes or so. Is that all right? So, yeah, just a few more key points. So, and I just want to touch on the antibiotic area of this. So there are studies, about 8 studies that have looked at long-term oral antibiotics for bronchiectasis treatment. all of them have been positive, and I want to highlight two. So azithromycin given 6 months here, again led by Conroy Wong, and you can see that those who had 6 months of oral azithromycin it took longer to have an infection compared to those who were on placebo. And overall, there was a 62% reduction of infections over 6 months and a 42% reduction over a year, even though they only had it for 6 months. And then I come to our paper, which also looked at the use of long-term azithromycin in children 1 to 8 years of age with bronchiectasis, both here and in Australia. And we showed that in those who had the azithromycin, infections halved, admissions decreased by a third, the antibiotics for other infections halved, and weight increased by a third. So Cochrane Review, which as you know, usually says more research or doesn't really come out particularly positive, in this instance has come out positively saying prolonged oral antibiotics driven predominantly macrolides, and azithromycin, which was used here, is a good medication. And the 2 sets of guidelines that I've referred to have recommended them in certain settings, if you have more than 3 exacerbations per year or 2 hospital admissions. So here we are in New Zealand, and we have contributed 2 of the vital papers to this finding. So do you think we can actually access this medicine? No. Our bar is far too high. There is a similar story with nebulized antibiotics, where many studies have shown an improvement in outcomes for adults predominantly with bronchiectasis. And again, a prolonged study using gentamicin, which is as cheap as chips, showed an incredible benefit. We did a very small study in children showing reduced inflammation and a reduction in the use of other antibiotics. So we can get nebulized antibiotics for our population with cystic fibrosis. But again, here in New Zealand, we have a huge amount of disease. This is proven as much as anything that we use. We have no access to this medication. The bar is too high. Thinking of Cam last night. Stay positive. So I've got a few positive things that I want to leave with. The first one's a bit, it's a lot of words on a slide, but it's just a concept. So one of the things is we always talk about prevention, and we always say it negatively. We should be able to prevent this. But I want to turn this round. I want to say we can prevent this. So some of these will be touched on later today, and some were already touched on previously. And really what we're saying is most things in the yellow are setting up factors or contributory factors, and by modifying these, we can likely prevent the development of disease. And I think that's a positive thing. And I want to come to the central premise. And that is that we have infections, we develop chronic symptoms, we move in a proportion to bronchiectasis. Can we do this? And in children, yes, we can. So in children, 52 children who had paired scans over a 5-year period, we showed that 46%, nearly 50% were stabilised, but a third improved. So this is reversal of disease, and some to the point of cure. Now, you cannot get this in adults, or very rare. So if we diagnose these kids early, this is a really positive thing. We can reverse this disease. And just a couple of examples. So you can see this young girl, 14 months of age, with disease. It's gone a few years later. This very young boy, less than 1, with disease, it's gone a few years later. And all of them were definitive. More positives, 2 more. And that's the foundation. So we've heard about the Bronchiectasis Foundation. Kia kaha to my whānau. And the other positive is our ESMA Foundation. And I think that the Tiha Ora is absolutely fantastic. And I also think that, let's think about this. We can prevent the disease. We can reverse the disease in children, and we can prevent the disease. And we can prevent it all together if we work all together. And I just hark back to Dr. O'Sullivan saying how resourceful and resilient our families are. And that is, I absolutely I believe that to be true. And I do think that working with the families and us working together and following the strategic outlines, that we can really change the picture of bronchiectasis in New Zealand. Thanks very much.
Following orders.
Oh, good. That'd be a first.
Good man. First man.
Emotional, I'm sorry. Kia pai ki te ro mea Māori e, kia uai tō mana e, mana motu hake, mana tuturu e, tino rangatira. Mana mori, nau mai haere mai, motu hake, nau mai haere mai, mana tira tana, tino ranga tira tana. This waiata is a link to what we've just heard from these three people. Cameron talked about the seed that was sown, and did Esther not do that? She sowed the seed of self-determination, did she not? Her parents, since she has passed, have nurtured that seed. This lady here is the strength of the formidable team of the Bronchiectasis Foundation, who is going to guide us to keep that seed alive. Are we not?
Kia ora.
Thank you.
Kia ora.
Cass, I like your style. I think you're a good lobbyist. You've shared some knowledge, you've been open, and you've given us your opinions of what needs to be done. And it's so much appreciated to have someone like you as a leader in paediatric respiratory care that's driving this and having the professionalism and the knowledge to not raise the bar but lower the bar. And your rationale around that makes sense. And so we just want to wish you all the best in your work you're doing as a team, and I look forward to probably hearing your update, and you'll be back next year with the bar lowered. So thank you once again, Cass.